Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center, reporting for the week of December 4th, 2023. Today, after a COVID status update, I will talk about long COVID. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It is still causing sickness, disability, and death, and there's still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at wastewater and looking in the shaded purple area, which is the last most updated 2 weeks. If you take a look at the red and orange, we can see that they are climbing up. So that is indicating a increased percentage of sites that are having increases in wastewater concentrations of SARS-CoV-2. And I still think the best thing to do regarding wastewater is to try to find a site near you. The links to different resources are in the post. I added one thanks to one of our viewers from COVID-19 Poops. Our colleagues at UC Merced are doing some important work around wastewater. So that is now linked in the post in addition to the others that I had. Also the updated CDC wastewater tracker. I'll share a little bit of it today. I won't go into detail, but they did do some updating, which I think is overall a good thing. When I take a look at my area here in Oakland, I'm taking a look at SARS-CoV-2. It is going up pretty steeply here. RSV and flu have not gotten off to as big of an increase as probably some other parts of the country. But definitely we're seeing a rise in SARS-CoV-2. So if you're interested in your area, I suggest you find a resource near you. And now getting into some of the other COVID metrics, I think things are starting to change here with respect to what we can really glean from some of these indicators, especially the ones looking at percent. So this is looking at percent positivity. So this is basically out of all the people that are going to get a COVID test, the percent positivity is ticking down just a little bit right now, but the number of tests has gone up pretty significantly. So we've been looking at about 70 to 80,000 tests for a while now, and now we're up to 95,000. So it's hard to say whether, what this really reflects. It really could be that just because we're seeing other respiratory viruses and people are getting tested, and because we're seeing now a mixture of flu, RSV, COVID, and other things. So this percentage may not be as helpful of an indicator, but we're just going to continue to watch it and keep an eye on it. It is still high at 8.8%. Same challenge here with emergency department visits, because here we're looking at percentage. So we may decide to switch to looking at overall number of emergency department visits instead of percentage. But for now, we can see it starting to tick down just a little bit, which is a good thing. So we'll just keep an eye on that. And this is updated through December 1st. So it is our most recent indicator. Unfortunately, when we do look at numbers, we're looking at hospital admissions here. That is continuing to go up. So we don't like to see this. We're now over 19,000 for the week ending November 25th, which is 1,762 more than the week before that. And these are for or with COVID. So this is not represented as a percentage, but just raw numbers. So we are seeing those go up. Those are more than triple where we were for most of the month of June. So still a lot of people every week being admitted for or with COVID. And of course, we don't like to see this heading in this direction. And when we know that there are 19,000 new hospital admissions, this is people who are suffering. Some portion of these individuals will have a poor outcome or suffer longer term issues like organ damage. And of course, some are ending up with post and long COVID conditions, which we'll talk about more today. And taking a look at deaths for the week ending November 4th, we have at least 1,143. And I say at least because every week they are adding more deaths to the weeks before as that documentation comes in. So each week I'm seeing that the prior couple of weeks are being added to. So with that said, we have been seeing somewhere around 1,200 deaths every single week, essentially for the months of September, October, and November so far. This is more than double where we were just this past June and July. This is still a lot of people losing their lives to COVID. And we know that many of these could have been prevented with prompt outpatient treatment and also if they had been fully boosted. So we need to make sure we are doing these things, particularly at those at risk of a severe outcome. And taking a look briefly here at influenza, this is for the week ending November 25th. So we are kind of in the swing of flu season here. So we're at 6.2% positivity. This is up from 4.9% the week before, and over 4,000 hospitalizations for that week compared to a little over 3,000 from the week before. And remember, this is compared to over 19,000 COVID hospitalizations, but we do expect the burden of flu to just kind of continue to increase here as we get further into flu season. Unfortunately, we've had 1,100 deaths so far this flu season in the US, and 8 of those were pediatric deaths. And you can see on the map there where we are seeing the highest incidence of influenza-like illnesses. So this is people presenting into outpatient and hospital and emergency department settings with respiratory issues. And we're seeing a lot of this across the South, but also here in California. And remember that a particularly high risk of bad outcomes from flu are those at the extremes of age, so those under 5 and those 65 and up, as well as those who are pregnant. And the flu vaccine does significantly reduce the risk of a bad outcome, and it is recommended for everyone 6 months and up. And RSV detections are definitely on the upswing. So these are cases, and we are fully into RSV season. So we'll just continue to keep an eye on this. And if you're someone in a high risk group, or have a little one, a baby, an infant who this is their first RSV season, or if you are pregnant, it would be a good idea to check in with your primary care doctor to see if you are eligible for the new RSV vaccine. So now I want to talk about our topic of the day, which is long COVID. Every few episodes, I've been providing pertinent updates on long COVID, and every couple of months, I try to do an overview on where we are just to help keep us on track. And always a lot. There's a lot moving in the area of long COVID. And so if there's anything that you are aware of that you think I'm missing or you'd like me to review, please don't hesitate to send us a direct message or put it in the comments, or you can email us at admin@rootsclinic.org. And because there is a lot, and although we do try to keep up to date, I know that a lot of you out there are also doing the same thing. And a lot of that is because there are so many people suffering with long COVID, and we really urgently need some answers. So it is one of those situations where it feels like kind of all hands on deck, and there are multiple studies going on all over the world. So I have linked a few prior briefings that I'll refer to today that may be of interest, but I will also be reviewing some of the highlights and some also new information today. So as we all know, COVID is still relatively new to us in the broader scheme of things. And so long COVID is even newer. And there's still a lot we don't know about COVID itself, and even more we don't know about long COVID. We know that COVID itself is quite unpredictable and can affect nearly any organ, and the same is turning out to be true for long COVID as well. We still cannot predict who will get long COVID or when. Will it be after a first infection, second, or third? We still don't have a cure or really treatments per se. We're still really early in our understanding of long COVID, so the field of research can kind of feel all over the place. It's not a bad thing. There are people all over the world looking at different aspects from different angles with different areas of expertise. Different teams are proceeding on different fronts. There are long COVID clinics that are certainly conducting clinical trials. There are a number of researchers looking at it from all different aspects. So it kind of feels like we're just having to proceed forward on multiple parallel tracks, which can get a little bit confusing and somewhat overwhelming. But I think it just speaks to where we are in what I would call a crisis on top of a crisis. So the long COVID burden of just disability and suffering on top of the ongoing crisis of the COVID pandemic, where people are still obviously getting infected at high rates, getting hospitalized, and so on. And so we continue to pile on more and more cases of long COVID without a thorough understanding of what we're dealing with and how to deal with it. So all of this can feel very unwieldy. So in my mind, when I see studies on long COVID, just to organize it for my own brain, I kind of put them into a few basic categories, and those are understanding long COVID, describing long COVID, preventing long COVID, diagnosing long COVID, and treating long COVID. And I think that some of those are maybe overlapping a little bit too, but I think that that pretty much covers the main areas that we're seeing where we have emerging studies and things like that. So I'll kind of go through them. Understanding long COVID and describing long COVID might seem the same, and they do overlap, but they are different. So I'll take them each one at a time. So in terms of understanding long COVID, this article is still one of my favorites. I've reviewed it in detail before. It's linked in the post. It does an excellent job of walking through the major findings up until about January of 2023. And I know that's a long time in COVID time, but still it lays a foundation that I think is important. And I've linked the prior briefing where I went over this. I also discussed ME/CFS in that briefing, myalgic encephalomyelitis, chronic fatigue syndrome, which bears similarity to long COVID. So it is worth understanding about that. That briefing is linked in the post if you want to check it out. But a couple of highlights here in terms of understanding long COVID. So just a couple of highlights. One thing, it did outline some risk factors, and I'll offer just a couple of the examples from the article. First, the risk of long COVID is significantly increased with increased severity of the acute COVID infection. So if you had really severe COVID infection, we're in the hospital, it is several fold more likely that you'll end up with long COVID. But having said that, the vast majority of people who have gotten and survived COVID have what we would consider a mild case of COVID. So for that reason, the vast majority of people with long COVID did have what would be considered otherwise a mild case of COVID. But still important to note that the severity of the infection is a risk factor for long COVID. So things that we can do to reduce the severity of the acute COVID infection, like vaccination, like antiviral treatment, from that perspective would reduce the severity of the acute infection and potentially reduce the risk of long COVID as well. But keep in mind that there will be people who've had a very mild acute case that could have very debilitating long COVID. And the vast majority of people today walking around with long COVID or resting with long COVID had what would otherwise be considered a mild case. Next, diabetes, type 2 diabetes, a common chronic condition, which is actually increasing worldwide in general, was also found to be a risk factor for the development of long COVID. And remember that we are also seeing increased incidence of new diabetes after acute COVID. So I've talked many times about kind of this two-way street between COVID and diabetes. And to some extent, it seems that we have the same thing with long COVID and diabetes as well, where type 2 diabetes can be a risk factor for long COVID, and type 2 diabetes can also be a post-COVID sequelae or consequence of having COVID. And last example I'll provide here in terms of risk factors that I thought were important to note are that there was seen to be a higher incidence of long COVID among those who did not rest when they got acutely infected. So it's difficult. We got things to do. We've got to work, we've got to earn, and all of those things. But with that, I think it's important to note that which is why I always mention every week, I encourage you to rest if you don't feel well. There was some evidence around the incidence of long COVID being higher among those who did not get the opportunity to rest when they had the acute infection. So word to the wise there. And Another risk factor that was pointed out here was a history of Epstein-Barr virus, which causes infectious mononucleosis, and it can result in chronic fatigue syndrome, which again, I discussed in that linked briefing. And a history of Epstein-Barr virus has been shown to be a risk factor for long COVID. And this leads us into the theories about why people get long COVID. And notice I said theories because we really are at that stage of still learning. What are the underlying mechanism? What is actually causing long COVID? And I'll review these briefly, but first let me say that in an ideal world, we would understand the mechanisms first, so then we could figure out how to diagnose and to treat. And diabetes may be a good example where the more we know about diabetes, the more we learn about the underlying causes, the better we're getting with our treatments. And just like diabetes, it seems like there just isn't one cause, so there won't be just one treatment. If you can't make insulin, that's very different than if your organs are resistant to the insulin. Both result in a clinical picture of diabetes, but we have to treat them different because the underlying cause of it is different. And in this case, with long COVID, with millions upon millions of people suffering, it would be great if we sort of had those mechanisms dialed in and we knew how to figure out what was what in which patient. But with so many people suffering and in the stage we're in, we really can't wait, I think, to have a perfect understanding of the underlying mechanisms before we begin trying to diagnose and treat. So, very imperfect situation, but it is the situation that we're in. So, by way of review, the main working theories at this point around what is causing long COVID seem to be first would be a persistent reservoir of SARS-CoV-2 in the tissues. So, viral persistent. And this seems to be one of the leading theories, I would say. Secondly, is immune dysregulation. So, we know that COVID affects the immune system and that the immune system can become dysregulated. So, what could that look like? Well, this could be with or without the reactivation of other underlying pathogens or diseases that might be present in the body. So, for example, the Epstein-Barr virus that I mentioned, or a herpes virus, and or others that basically were like dormant in the body, and then because of the COVID and the immune dysregulation that COVID causes, that then those viruses get reactivated. So if you had, for example, Epstein-Barr get reactivated, could that be what is contributing to the long COVID symptoms? Third would be impacts of SARS-CoV-2 on the microbiota, including the virome and in the gut. And so basically the disruption of the gut microbiome. So could that be leading to long COVID? Next would be autoimmunity. So is there a possibility that the body is developing antibodies against itself, essentially, and that is what's causing the long COVID symptoms? There is also some thought about what is called molecular mimicry, and that just basically means that the virus may look to some of our immune cells like the self. So that's kind of related to autoimmunity, but it may have to do with the parts of the immune system kind of mistaking the pathogen for the self. Another reason that's been put forward is the blood clotting, so the microvascular blood clotting. So, and the inside of our blood vessels basically getting damaged. So we know that COVID does this. So could this also be persisting and causing the symptoms of long COVID? And then last but not least would be direct insult to the organs, so direct damage to the organs, and certainly in people who were hospitalized or went to the ICU or had a prolonged hospital course, this may be more likely to be the case. But once again, because COVID can affect any and every organ, essentially, this is certainly a theory that's worth continuing to explore. And I think it's safe to say that each one of these underlying causes is going to probably require a different approach. Maybe a different approach to diagnose, maybe a different approach to treat. Also, there's no law that says it could only be one of these in an individual patient. It could be more than one of these. But for example, if it's viral persistence, then we're thinking about clearing the body of the virus. But if it's the gut microbiome, we may need to be thinking about repopulating the gut with the probiotics or the positive bacteria, for example. If it's clots, we're going to be thinking about dealing with the clots, and so on and so forth. So depending on the underlying mechanism, this may affect everything, how we diagnose it, how we treat it, maybe even how we're thinking about prevention strategies for long COVID. And I'll speak to that more in a moment. So there are different ways to go about testing all of these theories or investigating all of these different theories. And there are many studies underway to do that. So that is very hopeful. Clinicaltrials.gov is where you can look up long COVID and see that there are hundreds of studies. The last time I looked, there were 189 that were recruiting people into those studies. There are treatment trials underway. So I know that doing treatment trials when we don't understand all the underlying mechanisms might really feel like putting the cart before the horse. And that is completely understandable, especially when we don't know if we could even make somebody worse or if nothing's going to change. And so it does feel a little bit like putting the cart before the horse. But again, because of the urgency of the situation, it's requiring us to proceed this way on multiple parallel tracks. And so one of the many challenges that comes from this is that if you can only help a subset of people with one of these treatments, then, and we don't have a grasp of who's who or why some are helped or not, that is going to be a challenge because we don't have a complete understanding of the underlying mechanism for each patient. And for each patient, this could really end up feeling like trial and error because at this point, we don't really have a complete way of knowing what is the underlying mechanism for each patient. So at this point, it does not seem like a one size fits all kind of situation, which means that the treatment is not going to be a one size fits all either. But right now, we don't have a great way of stratifying who is who. So that's just kind of the reality of the situation that we're in. I think another thing to say about it not being a one size fits all situation is that the presentation of the long COVID may depend on which variant or variants cause the acute infection or repeat infections. So we borrowed and adapted this timeline from Nature magazine, and it shows roughly the timeline of the different variants. And actually, the article that we pulled this from was reviewing the different symptom presentations seen with the different variants. But I think we are recognizing that not only may COVID have different presentations based on the variant, but long COVID may as well. And then maybe the treatment might have to be different as well based on when you got the COVID that led to the long COVID. So I'll talk a little bit more about that in a moment, but especially with the theory of viral persistence, right? If we think the virus is still hanging around and we're going to try to clear it out, we may need to be aware of which variant it is so that we can pick the treatment that is tuned to the variant, if applicable, and that it's tuned to the variant that the patient actually had. And we may find that some treatments work better against some variants or not. And again, this may only be relevant to a subset of patients where viral persistence is what's causing the long COVID. So still obviously more to learn there on just understanding the long COVID in the first place. Now, describing long COVID. So describing long COVID is also daunting. There are hundreds of symptoms of long COVID. And there's no way that we're going to be able to classify or categorize all of this that's going to be perfect. It's just not going to be perfect. I reviewed in great detail a publication of the RECOVER trial. I linked both the article as well as a prior briefing in the post. And it really had to be kind of a nuanced discussion because it's a massive and important undertaking that they're doing. And we wanted to talk it through. We wanted to talk through the potential for unintended consequences and what we might do to avoid that. But the bottom line here is that having a general framework for categorizing long COVID and its symptoms is important. And it's also important to ensure that it's not used to exclude patients from research or trials. That is critical. So if you're interested in that discussion, you can check out the prior briefing on the RECOVER trial. And preventing long COVID. So most of the studies published to date on this are retrospective. So we're having to look back to see what things did we do, primarily what things did we do for the COVID infection, and then did it reduce the risk of long COVID or not? So I did 2 recent reviews on vaccines and their impact on reducing long COVID. One was a pretty good meta-analysis. The other was a really large population-based study. I've linked both of those previous briefings in the post. They're pretty compelling overall, I would say, where the risk of long COVID is pretty consistently reduced among those who are vaccinated compared to those who are not. But it's not in everyone. And there have also been studies looking at whether having received antivirals reduces the risk of long COVID. And there's a recent meta-analysis on this I'll briefly discuss. So this is a systematic review and meta-analysis. So remember, a meta-analysis combines the results of multiple studies that are addressing the same research question. And this meta-analysis ended up looking at 6 studies with data on long COVID and antiviral therapy. And this is pretty big when they took it all together. It was about 3.35 million individuals from different countries. And this meta-analysis did have a number of limitations. One of them is that they were looking at different antivirals, so remdesivir and Paxlovid and molnupiravir. And also, as I mentioned, these were observational, so they aren't trials. They're looking back at what has already been done, and these aren't controlled, or they weren't attempting to be the same as each other. And so that's kind of the nature of the meta-analysis. And then, of course, we've talked already about limitations around defining long COVID itself. And so these are among some of the limitations, but nonetheless, the results of the studies all pointed in a similar direction. And the main conclusion here was that long COVID or post-acute sequelae of COVID was significantly reduced in patients who received antiviral therapy early in their COVID infection. So we know you have to get the antivirals early in the COVID infection in order to reduce the risk of a bad outcome, but doing so also reduced the risk of getting long COVID by 27.5% compared to those who didn't get the antivirals. And also the risk of hospitalization and death related to post-acute sequelae of COVID were also significantly reduced by 29.7%. So almost by 30% reduction in hospitalization and death related to post-acute sequelae of COVID from having received an antiviral in the acute COVID infection. So when we take a look back, there does seem to be a reduction in getting long COVID after getting vaccination. Also, there does seem to be a reduction in getting long COVID for those who were treated with an antiviral during their acute COVID. So these are clues, and it's great for the people who were helped by this, the people who didn't end up getting long COVID, but we still don't know why it's only helping a subset of people. And we really don't know exactly why it's working. So we don't know exactly the mechanism here. We know that antiviral drugs keep the virus from replicating, so I think we can try to connect some dots about it. But I don't think we're truly at the point of knowing the mechanisms of preventing long COVID, and whether vaccines or antivirals will be able to treat some people that have long COVID is a whole other question. I'll get to that in a moment. But as it relates to prevention, so far what we're seeing is that vaccine and antivirals do seem to have an impact before you have long COVID. So that is certainly something to keep in mind in terms of getting vaccinated, boosted, and also in terms of getting timely treatment if you do end up positive with COVID. Now, diagnosing long COVID. So regarding diagnosing long COVID, I'm not going to do a comprehensive review of this today. We talked already about categorizing and describing long COVID. But I think there's a whole world of how are we going to diagnose, maybe with lab tests. I think that's what we're all just hoping for, is that there's going to be some kind of specific lab tests that are going to point us in the direction of long COVID. And in a past briefing, which is actually the first one that I linked in the post, I reviewed some very interesting information about the plasma proteome, which is basically all the different cells and proteins that we find in human plasma. And it turns out that the plasma proteome looks different in people with long COVID than in people without. And so you can check out that study and the briefing. Both of those are linked in the post. And this recent publication I thought was promising as well. And it's a preprint, so I'm not going to spend much time on it. But similarly, they analyzed the blood plasma of patients with long COVID and found elevated levels of 4 proteins in particular. And the authors believe that this combination of proteins in the plasma may be able to predict long COVID. So again, preprint needs to go through all of the reviews, and definitely more study is needed on all of this. But these are very promising developments. And I say that because these could be like markers that are specific for those people with long COVID, because most of what we can look at now is not very specific. So we're looking for antibody profiles that are kind of general. We're looking at inflammation markers or immune issues in the blood, things that we might sort of see in a variety of conditions, or things that aren't going to point us to something very specific. So I highlight these 2 studies because I'm hopeful that there is something more specific on the horizon. So we'll keep an eye out for this study to make its way through peer review, and of course anything else that looks promising for being able to accurately diagnose long COVID. And hopefully one day what we get is a very specific type of diagnosis that even points us in the direction of the underlying cause of long COVID for that patient. So hopefully that can point us to the right treatment for that patient. So obviously we're not there yet, but these are examples of promising things that are underway. And the last category is treating long COVID. And of course, this is the area where I think we're all feeling like it's taking a long time to get to a point to where we have treatments available. We're not there yet. We know that there's a lot of things that are being tried, repurposed, and so on. And most things are just having these mixed results, which are feeling kind of all over the place. For example, when it comes to vaccine for people who already have long COVID, the results have been very mixed, where some people improve, some people stay the same, and some people get worse. And same thing with antiviral treatment. So we still have just a ways to go as it relates to all of this. Probably is pointing to different underlying mechanisms in those different groups of people. And so these are all clues, but in the meantime, there are folks having to volunteer for these trials, and sometimes it's not working out well for them. And so there's just a lot of frustration and trial and error going on. And so I just wanted to acknowledge the challenge with that. I did want to briefly share this case study, which I'm sharing because even though they only discussed 3 patients, the results are quite striking. The authors do allude to the fact that there are others, but that these 3 they felt were the most descriptive and good examples. They were different ages, gender, medical history, vaccination status, and duration of their long COVID. But each of them were given monoclonal antibody treatment, and each of them experienced the same complete remission of their disabling disease. One thing about these 3 patients is that they all had very severe disabling long COVID. And within 1 week of receiving the monoclonal antibodies, they basically were able to go back to their normal life. They had a normal state of health, their previous lifestyle, their occupation, and exercise tolerance. And this remission is still sustained to date, over 2 years and counting. So this is, of course, very promising for these 3 people and for whatever subset of patients that this would be effective for. Unfortunately, again, we don't know what subset of people that is. And anecdotally, we've heard of people that have gotten worse with monoclonal antibodies. So once again, I don't think any one thing is going to be the end all for everybody. But when something can cause such a rapid and complete remission that is sustained in people with severe long COVID, I think it's urgent that we figure out which subset of patients is going to benefit in this way and get this treatment to them as soon as possible. I will note that these were pre-Omicron infections that led to their long COVID, and of course, the monoclonal, which was Regeneron, which is the one that we were able to use pre-Omicron. We don't have any monoclonals right now that are approved. So that kind of puts another wrench in the idea. But we know that there are new monoclonals that are being worked on. I've talked about some of those in a prior briefing, especially the ones that look like they could cover a lot of different variants, including even future variants. So I've linked that briefing in the post because I also find that very promising, not only for long COVID, but just for treatment of COVID for people who can't take the currently approved treatments. But I think once again, we're learning things piecemeal and they will be coming together. But I think it's important to note that long COVID is not just one thing. There's not going to be one solution. We still do have a ways to go. And in the meantime, there's a lot of pain and suffering and disability and frustration for millions upon millions of people. So we need to urgently move forward on all these parallel tracks that I've discussed. And if you or someone you love is suffering from long COVID, I hate to say that it seems that there will be advocacy required, which is much easier said than done, especially when you're fatigued and exhausted and frustrated. And I would say for loved ones, please be your loved one's best advocate. Do what you can to support and listen and understand the frustrations and the challenge that comes with this condition. And if possible, help to do that legwork and that research. Where is there a trial near me? Where is there a long COVID clinic near me? Who can I talk to? Get connected. There are a number of long COVID groups and folks that are advocating. So many hands make lighter work. So just know that there are a lot of folks out here working on this. There are hopeful things on the horizon and there will be much, much more to come. So we'll continue updating here to the best of our ability. And once again, if there's anything you feel that we missed or you'd like to see covered, please email at admin@rootsclinic.org. So as we've been saying week after week after week for years now, our best bet is to avoid getting COVID infection or COVID reinfection. And if you're someone who should be treated, get treated. And the only way that you're going to be able to get treated timely is to get tested timely. Find out where you can get tested, find out where you can get your free rapid tests, order the ones from the government, check with your insurance companies and your local community health center like Roots Community Health Center to get more free antigen tests. And how do you know if you should get treated if you get COVID? Well, it's recommended for everyone 50 and up and anyone with an underlying condition. The list of underlying conditions is very long and it includes a lot of really common things. So don't assume that you won't be eligible for antiviral treatment. And actually, up to 3/4 of the adult population fit into the category of people at risk of a severe outcome based upon that list. And the link is in the post. So please check that out and make a treatment plan. Remember that we are still learning about the effects of repeat infection. We're still learning about post-COVID and long COVID, as we've described here. And what we know is that just because you caught it once and did fine, that is not a guarantee about next time. So please do what you can to avoid getting infected or reinfected and spreading it to others. Gathering outdoors is just about always safer than gathering indoors. If you will be indoors, please make efforts to improve indoor air quality, add HEPA filtration units, keep that central air running with the proper MERV 13 or higher filter, open doors and windows where possible, and wear a high quality filtration mask like an N95, KN95, or KF94. Please don't show up to work or school feeling sick and exposing others. Stay home and rest. If you have to go out, a well-fitted N95 mask could keep you from sickening or even killing another person. And consider using rapid tests for pre-event testing. And if someone's positive, they'll just have to excuse themselves. A positive antigen test, believe it. Also, keep a guest list. So if someone turns positive later, you can contact the group. And we're heading into another set of holidays. So please consider for whomever you're going to be gathering with, maybe everyone make an agreement to mask and be super careful for 10 to 14 days before your gathering. Mask on your travel on the airplane or bus or train. Let's break those chains of transmission. Let's avoid having a super spreader event. We heard about a number of them over the Thanksgiving break. Let's do what we can to avoid that. So now's the time to start making those plans. Everybody who's going to get together, mask up for 10 to 14 days to make your gathering safer. And remember to eat a balanced diet, incorporate fruits and vegetables, avoid those sugary drinks, consider a multivitamin supplement. If you don't have a primary care doctor, please get one. Get your blood pressure checked, your baseline labs checked, like sugar and cholesterol, your blood count, your vitamin D. Get some regular physical activity unless you're sick. In that case, please get your rest. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.